Please feel free to submit your questions at any point during this webinar using the questions pane found within your GoToWebinar control panel. Within 24 hours of the conclusion of today's session, you'll receive an email with instructions on how to complete the activity evaluation and how to access your CE certificate from within the Pediatrix Continuing Education portal. Please feel free to email the Continuing Education team if you have any questions at continuing.education@pediatrix.com. We're delighted to have Dr. Alireza Shamshiraz join us for today's Grand Rounds webinar. As mentioned, his biography can be found within the handout section within your GoToWebinar control panel. Given we have an esteemed speaker joining us from Boston Children's Hospital, we want to take this opportunity to remind clinicians about the Boston Children's Care Connect, a complex patient referral program. The program is designed to provide guided access and centralized care coordination for pediatric patients with unusually rare and complex conditions. This is an available service and can be a particularly beneficial option when care is not available locally. To access this program, please email bchcareconnect@childrens.harvard.edu. Again, the email is bchcareconnect@childrens.harvard.edu. So without further ado, I'll pass the virtual mic over to Dr. Shamshiraz to kick off today's session.
Thank you very much, and I'm honored to be here today. My talk will be on the latest innovation in fetal surgery, and my objectives today is just want to show you what happened in the past couple of years in the field of the fetal surgery and how fast this field is evolving and becoming truly some subspecialty in the field that connected the multidisciplinary from the pediatric side to maternal fetal and OBGYN side. I don't have any conflict of interest, and my outline talks today are divided to the updates regarding the congenital anomalies that is coming down to this disease, and then also I will talk about some updates regarding the placental related disorders that is coming down to this disease in the left side. Regarding the fetal surgery centers, at this point there's hundreds of fetal centers around the country, and they do multiple surgeries such as in utero treatment. And the first disease that I will talk today, it will be a myelomeningocele that is very common. As all of you know, from the epidemiology side, this is one of the most common congenital anomalies in the field. And with that, giving the folic acid, it was significantly decreased the incidence, but however, we see about 90% of the time as a sporadic events in this group. And from the beginning of the disease, it started from the two-hit hypothesis. In a way of, if you see the study and they look at it, the babies was aborted, even before the 16 weeks in, they figure out that when you do have a myelomeningocele, it can be detrimental about, even more than half of the time, even at the 16 weeks to the neurons of the exposed to the amniotic fluid. And my today talk is regarding these spinal dystrophies. I will talk only about the open myelomeningocele. In reality, it divided to the two groups. We do have one as called as a myelomeningocele with a sac, and then the other group is myeloschisis. We call it as a flat lesion. Is less common. It's only about 10% of the open ones, and they don't have any kind of the sac. The two hypotheses of the hit is coming down from one from the congenital anomaly that you see on neurotube defect, and the other one is we do believe that if these neurons be exposed to the amniotic fluid, especially at the end of the pregnancy, because the amniotic fluid density is going higher, it can be detrimental to those neurons, and that's why you get that kind of understanding of why we want to do the fetal surgery and in utero repair for myelomeningocele patient. But also in the past decade, my team did a couple of studies regarding of comparing the this flat lesion that I call as myeloschisis to the myelomeningocele, and as you can see, even from the referral time, you see the intact motor function, lower extremity is much better in the flat lesion compared to the large lesion with a myelomeningocele, and that's consistent to the at the birth. With that said, we come up with another hypothesis of the third hypothesis regarding of expansion of these neuron nerves roots that also can cause the damage. But how can we fix it prenatally? And if you see it, the landscape evolved significantly in the past decade. We started and with open surgery, and then as you can see it, there's multiple other different techniques evolved in the past decade, which do have a more beneficial to the open fetal surgery, and now we'll go through those one by one. But with open hysterotomy, that has come down to the MOMS trial, that was a randomized clinical trial. I'm comparing the postnatal repair to the in utero repair for a selected group of the patient, and that was published back in 2011. As you can see, regarding that three hit hypothesis, we think that if you do the intervention earlier, it will be help and prevent for some of the sequelae of the neurotube defect. What is the benefits? The benefits that is proved on a randomized clinical trial, which published show in that New England Journal. It will reduce the need for a ventricular peritoneal shunt to the half, and there's a significant benefit. And also it will be increase the independent walking by 30 months of life, and it will increase it to the double, and it's coming down close to the 40% of these patients. However, in utero repair also do have some risk factors. Risk factors is any patient that do have an open fetal surgery do need to have a elective C-section at 36 weeks, and that's coming down to 100% of the time. And also it will increase the risk of the hysterotomy dehiscence 1 out of the 3 of these cases. That is also a significant risk. But still, the study shows the favorable outcomes for fetus, how we do the open fetal surgery. We do make it, lower segment incision on the abdomen. We do expose the uterus. We do the ultrasound. We're mapping the uterus. We make sure the incision that we're making away from the placenta. And then we make it some kind of incision that we try to anchor the membrane to the uterine wall. We expose the lesion, and then at this point, the pediatric neurosurgeon will come in, and they will try to repair the defect. The first step that we're doing for intervention is we give some medication to the fetus regarding a pain management, that is fentanyl, and also we give some bancronium to paralyze the babies. As you can see, and this is the first injection we do. You can see the uterus is very well relaxed, and the reason is we give a very high general anesthesia to the mom, and also in some of the cases we start in magnesium sulfate for prevention of any uterine contraction. At this point, the pediatric neurosurgeon will release the placo, and after the releasing the placo, the intention is try to close the defect, and mostly we do the primary closure. That means, mostly we do myofascial flap, and on top of that, we do the primary closure of the skin. The neurosurgery time is usually between 10 to 20 minutes. And here you can see one of the cases that we did perform a primary closure. But after the primary closure done, then we replace the amniotic fluid by LR or ringer lactate, and then we close the uterus in 2 or 3 layers to be completely closed and prevent of any kind of dehiscence or any kind of leakage of the fluid. But with that said, again, even through the best techniques that we've done, it's a good number of the patient will do have some kind of uterine thinning at the end of the pregnancy. The next step that you see from the open fetal surgery was the people in South America started doing a technique they call as a mini hysterotomy. That means instead of doing the incision about 5 to 7 centimeter, they come down to the incision about 2 to 3 centimeter. Here is a technique that they do. Again, they use the same principal techniques that we did for open fetal surgery. Again, first you do the anchoring stitch. Here you see the anchoring stitch, and those means you're anchoring the membrane to the uterine wall to prevent any choriamnion separation in the future and separation of the membrane from uterine wall. And then, slowly with a bow view, you make it, you're going down to find the amniotic sac. Here you go down slowly. Again, same, the patient is on a deep general anesthesia, and you see a very relaxed uterus. We don't want any kind of contraction of the uterus. And then when we enter the, amniotic sac, we do use the Alexis. And now we get a better chance of expanding that incision is about 3 to 4 centimeter to the bigger incision, and then expose the lesion to the neurosurgeon for repairing. As you can see, there's some studies outside, and one of the advantages that you start seeing is the gestation age of delivery start increasing. That means in a mom's trial was about 34 weeks. In these studies, it's usually they get to the 36 weeks, and also the chance of the P-prime slightly decrease, and then the Hisen is also, slightly decrease. With that said, again, if you see it, it look like a less minimally invasive compared to the big incision on a uterus. The next step that, I was working and collaborating with the people in Texas in my past decade of the life is another technique we call as a laparotomy assisted fetoscopy repair. The technique is in a way of we do the deep general anesthesia, and then we extrude the uterus. We put a 2 or 3 port. We drain the amniotic fluid, and then we put the CO2 gas. That means in reality, we make a space like a laparoscopy surgery that the surgeon can continue with the surgery. And this is one of our primary cases that we did the primary closure after releasing the plaque. And at the end of the surgery, if you realize there's only a 2 small incision, these are incision about 2 to 3 millimeter on the uterus, that is much less invasive compared to the complete open fetal surgery. We did start from the low fidelity. We practice hundreds of hours before we move it to the human. And then this is some of the backs that we repair back in 2017 and 18. The techniques evolved during the time. One of the evolving is because we put a CO2 gas inside the uterus, the membrane was get pretty wet. Therefore, we try to pretty dry. Therefore, we try to wet the membrane with fluid, and also we be very cautious about the anchoring the membrane, and for the place that we put a port, and then we double check at the end of the surgery that all of those stitches intact and there's no choriamnion membrane separation at that point. But at the beginning of the study, we put a CO2 gas inside the uterus. We get a lot of criticism, and these are all the criticisms that we got it. Acid-base balance, that we're thinking about the acidemia, the CO2 inside, therefore the pH can go up. There's any kind of brain damage to the baby. There's any kind of prevention of the growth of these kiddos. And by time there was more and more studies that's come out that show that safety as putting the CO2 gas inside the uterus. This is a series of the study that came from the group from Baltimore, and as you can see, is during the surgery they did a chordocentesis, and they look at the pH and the rest of the elements in the cord blood, and as you can see, all of those elements was normal in the 3 patients that they done. This is another series from 7 patients from a group from the California USC team, and then as you can see is the pH of all of those was normal after a prolonged time on the CO2 gas, and this is usually about a couple of hours at the end of the surgery. We also did a couple of studies regarding Doppler changes in umbilical artery and ductus of the babies during the surgery. We did see some transition changes, but again, none of them was permanent, and the outcomes was pretty similar to the open. We did look at the meticulously to the amniotic membrane and placenta, make sure there's no side effect of the CO2 gas to this membrane or placenta, and we couldn't see anything. And then we did look for neurodevelopment of these babies, that we didn't see any kind of significant changes. We followed them for the growth, and we didn't see any kind of significant decrease on the growth or any effect on the growth of these babies. And also we follow them for subsequent pregnancy. And I think this is one of the advantage of this technique. With this technique, you can have a vaginal delivery. That is very important. And then for subsequent pregnancy, again, as you can see, there's no complication on those pregnancy. And this technique called as laparotomy, the fetoscopy approach, appear to very low risk when you compare it to the open fetal surgery that we do know is about close to the 5 to 10% uterine rupture in subsequent pregnancy. That it can be a very devastating for the family and the entire system as a physician. The next technique is coming down to the complete percutaneously. That means if you start seeing it, then we're moving more and more minimally invasive. This technique that is done in a couple of centers in Brazil and a couple other centers in the state and in UK. The outcome that is from the neurological standpoint is pretty similar, but one of the criticized this technique has still is regarding the prematurity of the baby and the risk of the preterm premature rupture of the membrane that is pretty high. Therefore, recently the group in California went up to another minimally invasive technique called as a percutaneous mini laparotomy. That with that technique, if you look at it, the chance of the P-prom was decreased. Again, this is a very limited number of the patient, but it's also promising. And you can see that the P-prom and also the gestational age of delivery is increased in this group of the patient. The way that they do it, again, they make a small midline 2 or 3 centimeter incision for anchoring the membrane, and then they start putting the ports. And at the end of the surgery, if you can see it, the advantage is a very small incision on the abdomen. Comparing all of these techniques together, if you see it, by time, when we move to the more and more less invasive techniques, we see more and more benefit to the pregnant person, and that's very important. And that's one of the tasks that on the fetal surgery, what we want to do is minimum risk to the mother. The next disease I will get to it is a congenital bacterial hernia. As all of you know, the group that we're dealing is mostly on fetal intervention is a severe. The majority of time, these are the left-sided disease. Ultrasound and MRI is a good way that we can predict some of these and severity of the disease, and also the liver herniation is important element. With that said, for severe disease, one of the intervention that was proposed and offered was a procedure called as fetoscopy endoluminal tracheal occlusion, or in abbreviation, we call it as a fetal procedure. The way that we do it in the fetal procedure is, again, ultrasound, with ultrasound guided, we put a port there's a 10 French port close to the fetus mouth. And then we put our scope down and we go and navigate through the amniotic fluid. Here you can see the baby's lip, upper lip, lower lip. You can see the baby tongue. We move in top of the tongue. We go to the back of the throat, and that is getting to the here to uvula. And then we try to find the trachea. It's the same concept of how you do the intubation for a neonate. And here you can see the vocal cord, and we're coming down to the trachea, and then here you see the bifurcation. When we do see the bifurcation, then this is the time that we tread down our fiber with the balloon, and here we inflate the balloon. We put about close to the 0.7, 0.8 cc of the fluid inside the balloon, and we detach it. with this technique again, we close any kind of secretion of the lung outside. It will increase the pressure inside the lung, and will cause a lung hyperplasia, and will helping with the growing of the lung. Technique usually, we put a balloon between 26 to 30 weeks. Then we need to start thinking about removing the balloon at 34 weeks. And the reason is we need to remove it earlier because get some time to the pneumocyte type 2s to grow and make some surfactant. And also, you don't want to have delivered a baby with a balloon in place, because then the baby cannot breathe and it can die, and that's one of the severe complication with this type of procedure. Therefore, all of these patients need to be close to the centers that they put the balloon for the baby. And if anything happen as emergency, then we need to do some kind of exit procedures for this to remove the balloon, and the baby still be on a placenta circulation at the time of removing of these balloons. Recently, there's a randomized clinical trial that finished back in 2021, published in New England Journal. This is a 10 years of work, multi-center studies, and there were a couple of the institution from United States was involved. And in severe, group of the CDH, it did show that significantly would decrease the risk of the mortality in this group of patients. However, again, fetal intervention do have some kind of the complications, such as preterm delivery and PPROM, that you can see the risk will be increased, and especially for a patient with a severe CDH, early delivery is disaster. We did a feasibility study in the United States. This data published back in 2017. It does work, it's feasible. It's also safe in our hand in the United States. We also shows that, if we put a balloon, it will decrease the risk of the pulmonary hypertension and the ones that survive. And I think that's also an important thing to know. The next thing is lower urinary tract obstruction. I'm talking here about the novel scoring system that is coming to the play, and it can maybe helpful to targeting which group of the patient can benefit from the fetal intervention. As you know, that lower urinary tract obstruction is a hetero group of the disease, but the two most common cause is the posterior ureteral valve and urethral atresia, most common in male. Ultrasound is a good modality for diagnosis. Dilated posterior urethra that cause a keyhole sign, and also big bladder as a megacyst is easy to diagnose, and majority of the time the fluid is low. That means you had a low amniotic fluid, or sometimes we don't have see any fluid around the baby, called as the anhydramnios. And then there are, again, bilateral hydronephrosis in this group of the patient. But the luteal group divided to the two. That means it's divided to the one with the normal amniotic fluid in the mid-gestation, and there's another group that is called as luteal that had a very low fluid at the mid-gestation, all anhydramnios. The one that had a normal amniotic fluid, the outcomes is generally better. They mostly survive, but however, we need to keep in mind that the majority of those patients at the age of 2, they do have some kind of the chronic kidney disease. That means these are also a very complex group of patients that need to have a long-term cures after the birth. But the ones that had a severe luteal, that means at mid-gestation they don't have any kind of fluid or is minimal fluid, called as oligohydramnios. They had a couple of options. They can do the expected management, that the chance of surviving is less than 5%. They can do elective termination. Also, they can do the ultrasound guided vesicoamniotic shunt if they are a good candidate. With that said, the technique that we do is, we put some fluid around the baby, and then we use a pigtail shunt to put inside the bladder to drain the urine outside. And the objective here is only to help for growing the lung, because the lung needs some fluid around it. Pluto trial was a randomized trial about a decade ago that shows that if you put a shunt, again, you can increase significantly the chance of surviving in this group of patient. However, it's a very complex group of patient, and then definitely need a long-term follow-up, and they need to be cared by a very complex group of the physicians in the institution. Shunt is, again, one of the challenges that we have. European do have a, shunt called Somatics. We don't have it in the United States, but that's give them the capability of intervening earlier, even earlier at 13 or 14 weeks. And they believe that, if you do intervene earlier, it may prevent some of the kidney damage. Unfortunately, the shunts are available in the state. Usually we, start using them after, 17 or 18 weeks in a state. We, again, about 6-7 years ago, we come up with some kind of staging system to try to figure out which group of patient can be more beneficial for having shunt, and figure out if you drop to the stage 2 with these, criteria, is better to, benefit from the shunt. However, recently we come up with a novel scoring, and we added 2 important parts. One is, how big is the bladder at the initial, ultrasound, and then when you drain the bladder, after 48 hours, how much the kidneys make urine. Because if we do believe that the kidneys, make urine, probably that's the case that the patient will benefit from fetal intervention. But the urine that they make, it need to be a good amount of the urine, and we call it more than 80% of the initial volume. And also we look at the morphology of the bladder. It means, if you had a very big distended bladder, those are better candidates for the intervention compared to the Snow, wise man look like bladders that is pretty floppy. And the shunt dislodgement is an issue. That means, again, for years and years, we put different shunts, and then sometimes the shunt is taken by the kids outside, and sometimes go inside. And minimum average of the amount of the shunt that the patient needs to have is between the 2 to 3 shunts during the pregnancy. Therefore, meticulously we are working on a new type of the shunt that hopefully will come to the market in the next 1 or 2 years, and will prevent of some of these dislodgement problems in the field. Now I'm going back to the placenta, issue, and the evolving in the past couple of years, the field, and what advantage is coming, and what new things we can see. The first group, I'm coming down to the disease we call it the selective fetal growth restriction. Mostly we see that on a Can you hear me?
Yes.
Sorry.
We can hear you, but we no longer see the slides.
Sure.
Perfect.
Okay. Sorry. Selective fetal growth restriction in the twin pregnancy. This is what happened. That means they share the placenta in a not an equal way. One of them will have a better, share of the placenta, and the other one a smaller part. And then the definition of the selective fetal growth restriction is coming down to the different, definition. But most of the ones that we use in the United States is the one twin is less than 10 percentile, and then you do have an intertwin estimated fetal growth discordance more than 25. There's 3 types of growth restriction. If you have the normal blood flow, and we call it the normal blood Dopplers, we call it the type 1. Most of the outcomes are good. The mortality is less than 5%, and majority of time they can go to the close to the term. Then we do have a group that we call as type 2. These are the ones that had a persistent absent or reverse of end-diastolic flow. And these are about the ones that can, get to the trouble. And then we had a third group that we call as the intermittent absence or reverse. And then it's close about 5 to 10% of these babies, unfortunately, can die inside the womb too. But the complication is that, again, fetal demise, preterm delivery, and neurodevelopment delay, especially in the type 2 group. We try to, figure out how we can predict which one of these are the worst. We look at it. If you had the more intertwin discordance, it will have a higher chance that this baby can get to trouble, and the smaller baby can, die inside the uterus. And that, still there's a lots of controversy of what is the best approach to this. Expected management, sometimes we can laser them like a twin transfusion. Sometimes we can do a selective reduction or delivery if they're close to the end of the pregnancy. But recently for this type 2, we come up with a new definition of divide them to the two subgroup. There's a type 2A that the ductus venous Dopplers are normal, and then we come down to the type 2B that the ductus is abnormal. And the first, set of the study came from people from California that show if you had a type 2B, that means the ductus are abnormal, the outcomes is pretty small for the smaller baby when you do any kind of intervention, especially the laser. But recently, we did a multi-center studies. This is 5 centers through the board. We put it together. We look at what will be the outcomes for the type 1 compared to the type 2B, and then we figure out that in reality the type 2B, and even after the laser, the chance that the small baby can survive is pretty small. Therefore, in general, we do believe that if you divided the type 2 selective fetal growth restriction to the subgroups of type 2A and B, the chance that the 2A can survive is pretty good compared to the 2B, and that's the way that you can consult the patient and you can choose the intervention that you want to do. Now coming down to the another disease is my favorite one called as the vasoprevia. The definition of the vasoprevia, that means there's some vessel cords is passing through the cervix, and that's a dangerous situation. And the reason is when the patient goes to labor, when they're starting having a contraction, those fetal vessels can abrupt, and if the fetal vessels are abrupt, it will be a fetal demise. With that said, again, recently get more intention for intervention for this group of the patient. As you can see, the complication, if it's undiagnosed, it will be disaster, and then a majority of those will end up with a perinatal mortality. If they diagnose, then they need to stay in a hospital in the 3rd trimester. They need to closely watch, and majority of these patients need to be delivered at 33, 34 weeks at because we don't want them to get to the labor at all. The intervention that we can propose for selective group of these patients, especially type 2, that means that we call as a bilobate, is we can, with a laser at 32, 33 weeks, we can go inside the womb. We can laser those vessels that's passing through a cervix, and we can get rid of the vasoprevia. With that said, then the patient does not need to be admitted in hospital, and they can go and have a vaginal delivery, and they can go to the chair. These again, these are the advantages that I mentioned for the vasoprevia. Still, we have a small numbers of studies outside. This is only 2 studies in the United States, one from South, another one from California team. But it's promising, and that's the reason is even in Boston Children's, we are starting offering this treatment for the subset group of the patient with a vasoprevia. We did a Delphi study recently that we published in through that Delphi study. Majority of the experts around the world believe that the laser for vasoprevia need to be experimental, but they advocate the expert centers to try and figure out what is the benefits and complication. But still, this is some experimental in around the world and the United States. And coming down to the another disease, placental chorioangioma. This is a vascular tumors of placenta. Majority does not cause any problem, but the ones that you see big, and the big ones that I'm talking about, more than 4 or 5 centimeters, they can get kiddos to the problem. And the reason the baby goes to the problem is this chorioangioma, they're pretty vascular. They work like a AV fistula. Therefore, the fetus will have a high cardiac output. Through the high cardiac output, the baby can go to the high cardiac output failure, and then when you get to the high cardiac output failure, then the baby can become hydrotic and can pass away. There are definitely a certain group of treatment. We did approach as a laser ablation. That means one approach that we can do, and here you can see In this case is with the fetoscope, you can go and we can laser ablate the feeding vessels to the chorioangioma, and then will significantly decrease the high cardiac output, and it will be reverse or even prevent of the hydrops of the fetus. This is one of the cases that we did a laser and the patient went to the vaginal delivery at term. The other thing that we can do in a selected group of the patient, this is the vascular plug that we can put on the chorioangioma. And this is the case that you can see a very big vessels in the middle of the chorioangioma that we put these plugs. This is the after the plug that we put those plug in the big vessels in the chorioangioma and try to stop the blood flow to the chorioangioma. This is the placenta after delivery with all of those plug inside. And then again, this patient also went to the full term and did had a delivery of the healthy fetus. The other disease that now is getting more and more attention in the United States and worldwide is another disease we call as a twin anemia polycythemia sequence. This is different from twin-twin transfusion. With a twin anemia polycythemia sequence, one baby is severe anemic and the other baby is severe polycythemic. Mostly that happen because of the unbalanced blood distribution between the two twins, and mostly will happen with a very small as you can see here, with a very small connection on the edge of the placenta between the two fetus. There are some classification of what how we can stage them, and mostly if the stage become above 2, we need to do some kind of the intervention for these patients. There's a long list of the intervention. I do try to do intrauterine transfusion. That is the way it is. We do transfusion for an anemic baby, and then we do the exchange transfusion for a polycythemic one. But still, we don't resolve the cost. Therefore, I do believe that that's not the best treatment. I'm strongly advocate for now, if it's feasible, do the laser ablation like a twin-twin transfusion. This is one of the cases that we did a laser. As you can see, this is a place that we lasered. You need to have a very aggressive laser and do the Solomon technique. That is completely try to separate the two placenta from each other from the surface. But it's challenging because you don't see any kind of the poly-oly situation, and it can be very challenging and need to be done definitely in experienced centers in the United States. Vein of the gallon is also an interesting fetal anomaly that recently we come up with a new fetal intervention. Again, same concept as chorioangioma. That means, if you had a very huge vein of the gallon, the baby go to the high cardiac output, then you will start having polyhydramnios, and then you go to the hydrops and the baby will pass away. In a certain group of the patients, you can do the coiling and then decreasing the blood flow in the vein of the gallon. And you can decrease it to the 70 or 80% of the time. It will make the baby pretty stable after birth. The baby does not need any kind of the immediate intervention after the birth, and also we can prevent some of the hydrops and recovery inside the womb for this group of patient. This is we've done one successful case so far in Boston children. This is an open trial that if anybody diagnosed a patient with a vein of gallon, we're happy to receive it, and under research protocol we'll try to see if the patient met the criteria, then we can offer them this intervention that is ultrasound guided, is the minimum risk to the pregnant person, but also it can be a life-saving for this group of the patient. And then coming down to the last disease that I want to talk about, exit procedure exists in a board of the fetal surgery for decades, and the reason that we do the exit is we want to offer the fetal placenta gas exchange for multiple reasons. The mom should be in a deep general anesthesia with a relaxed uterus, and then we can do the different things on a baby when the baby is still on a fetal placenta circulation. The reasons or indication for exit, as you know, it can be a giant fetal neck mass, it can be a lung or mediastinal tumors, it can be chaos, it can be exit to the ECMO. But exit has come down with a complication. This is, what we show in the past. The complication, but less, close to the more than 10% of these patients will need a blood transfusion minimal after the surgery because is a much severe way of delivery compared to a cesarean delivery. But there are some ways that we can get out of these exit, and one of the things is we call it a diagnostic fetoscopy, and I think is very important in a way of we can with the fetoscope in a cases that we are debate about the intake of the airway, especially for the huge neck masses. We can put the fetoscope down. We go to the to the mouth and then go to the trachea. The same concept that we do for fetal for CDH. And if we figure out that the airway is intact, then the patient doesn't need an exit. Therefore, you can do the easy cesarean delivery and then hand the babies to the neonatology for easy intubation, because definitely we know that will be the easy intubation. This is the one case that we didn't perform in the past. The people in Leuven also did a series of the cases. They sometimes they put a small tube for easier for the intubation, and also there's a group in the Mexico that they try to put some kind of a wire. Therefore, there are some groups that trying to do this as a stepwise. If you had a baby with a severe and huge neck mass, one thing that you can do is you can do a diagnostic fetoscopy, and if you see the airway is intact, then you can prevent the exit procedures. But one of the biggest important thing that I talk about all this glory of fetal intervention, prevention of the mortality, morbidity on neonate, but definitely we need to almost keep in mind that we are working on a pregnant woman that will have no benefit from that kind of surgery. There are multiple complications that can come to the mom regarding the earlier delivery, from the pulmonary edema, from the infection inside the uterus, and you'd see I hear coded all of these interventions that we mentioned, all of them they do have some of these possible complication inside the womb. And then there's a long list of the complication that before intervention we do need to talk with the family. They do need to understand that this fetal intervention is coming with a risk, mostly can be happen to the mom, and also there's some risk to the fetus. I mean, not all the time you are successful, and sometimes in these complex scenarios, if you expose the baby to the preterm delivery, it will be will not good. That means you increase the risk that those baby cannot survive. With that said, I need to thank my research group for putting all of this presentation together, and also I need to thank my family for allowing me to spend a lot of time or many time of my life in a hospital and not be close to them for many of the good time of their life. With that said, thank you very much for your invitation, and I'm honored to be here, and I'm happy to answer any question.
Thank you. That was an excellent talk and very comprehensive. There are a few questions that have come in. Most of them are compliments of the talk. The first question is, can you talk more about the new shunts that are being developed? As a mom that lost her child to fetal hydrops after having 2 shunts attempted and running into loss of funding, basically, I would be interested in learning more. And we have this person's contact, and Nicole will send it to you just to protect their privacy. So I'm not exactly sure which shunt she was speaking to, but I will let you answer that question.
This is my this is what I'm thinking. I do think we're talking about a baby with a hydrops that also had a significant pleural effusion. And there are, again, the same type of the shunt that we use for low unit tract obstruction called of Harrison shunt, we do use on a pleural effusion one. But the most important part is we need to figure out what is the cause of the hydrops. If the cause of the hydrops is because of primary pleural effusion, usually the outcomes are good. But if the cause of the hydrops is because of something else, such as chromosome anomalies, think about Turner syndrome, think about Down syndrome, then even if you put the shunt, the outcomes are pretty bad, because we talk about the severe disease that now shows the manifestation as a hydrops. And there's a multiple other reason for it, fetal hydrops, such as, metabolic diseases, such as infection diseases. Therefore, the cause is very important. And we need to stratify the cause. If it's primary pleural effusion, the outcome will be good. But if it's secondary to any of these chromosome anomalies or infection or other metabolic disease, the outcomes are pretty bad. And usually we do not offer the fetal intervention for this group of patients. And I'm happy to, again, be connected to that person, and if I have anything more, I can help them.
Okay. Is there any fetal intervention for large bronchopulmonary sequestrations?
That's an excellent question. Mostly, again, because of the nature of the disease, we don't get to the problem. And majority of these patients, we need to have a resection after the birth. The advantage after the birth is because they are not connected to the airway tree. Therefore, after the birth, they are not expanding such as some of the CPAM that we see. Therefore, we had enough time that, move the babies to the pediatric hospitals and, can resect there. There are a few groups that they can get to the hydrops. If they get to the hydrops, one of the treatment that we did in the past is open fetal surgery and removing of that sequestration lung mass, and then close the chest and then close the uterus. Is pretty rare. That means in my career, I only done one. And usually, we don't get a problem. There are some, European data that they try to ablate the feeding vessels by ultrasound guided laser ablation. It's reality. I do not like that kind of intervention because, anytime that I want to bust something, I want to see it by my eyes, or at least I want to have a control of how much energy I want to get it, especially in the chest, because you're close to the lung, you're close to the many, many other, important organ. And it's not my favorite treatment, but again, the intervention will be very few cases, and I think in the good centers, the best intervention will be open fetal surgery.
Okay. Can you discuss the pros and cons of serial amnio infusions for bilateral fetal renal agenesis?
That's an excellent question. That means we do not offer it at this point in the Boston Children's. That is part of the NICHT trial. They call it a RAF trial. The RAF trial did have a 2-arm. One was used the serial amnio infusion for a bilateral renal agenesis, and the other arm is for a renal failure group. As the data was released in a Society of Maternal-Fetal Medicine in the February of this year, they hold on a bilateral arm. The reason is because they reached the primary outcome, and the primary outcome surviving up to the 14 days. However, they see many complications with that group of the patient. That's why the DSMB board asked for holding the study at this point, had a more investigation or understanding of why those complications happen. The data probably will be coming up very soon in New England Journal of Medicine, and you can read it by details. But at this point, none of the centers now offering any kind of the serial amnio infusion for bilateral renogenesis.
Okay. You know, with the vein of Galen aneurysms, with the embolizations, are you having success? And not one of the things you see postnatally, obviously, is that those can actually go across the venous system, get into the arterial system. Are you able to have pretty good success at getting rid of those lesions?
This is an excellent question. First, what we do the coiling, and we not completely close the entire system. That means, we try to decrease the blood flow to get the baby to the stable condition after the birth, and also get out of that high cardiac output. With that said, again, the inclusion-exclusion criteria is pretty strict. I will leave it to my pediatric neurointervention person. Is out of my field. I'm the only person here helping with a needle guidance procedure. This is an investigation. We did have one successful case in the Boston children so far. There's one successful case in the front, and this is the only 2 success case that I know. Definitely, we need to get more and more data before we really want to invest it and count it as a standard of care. But as many of you know, on the very severe and huge vein of Galen, the outcomes are pretty bad, especially after the birth, because the babies are very unstable.
Okay, well, that has all the questions answered, and greatly appreciate your time today. Very successful meeting, and we'll send you some follow-up after we close the webinar. But again, thank you very much for your time and your excellent talk.
Thank you very much for your invitation. Hopefully you enjoy it. Have a good day.
Thank
You too.
you.